Ultrasound physics is broken into 3 major chapters so that the information provided is bite-sized and easy to follow. This is part 2 of the lecture series where we focus on ultrasound modes, probe types, and tissue interactions. The basics of ultrasound and knobs and artifacts are part 1 and 3 of this lecture series. The full lecture is also available if you would like to watch this 1-hour lecture in one go.
Ultrasound modes. Beam mode or brightness mode. This is the standard method for image creation in 2 dimensions.
The returning echoes are displayed on the monitor as shades of gray. This represents a 2-dimensional image of approximately 3 millimeters of depth. Typically, the brighter shades of gray represents echoes with greater intensity levels. The best image is created when an object of interest is orthogonal to the ultrasound beam. The brightness displayed on the screen is determined by the amplitude of the returning echoes. Anechoic is complete or near absence of returning sound waves and appears black on the screen. Hypoechoic has very few echoes and is represented darker than surrounding tissues. Hyperechoic signals are high amplitude and represent wider than surrounding structures. M mode. The best temporal resolution is obtained when a single scan line is used to emit and receive. We do this by stimulating one of the piezoelectric elements and not all of them. Motion or M mode does this. If reflection occurs, the signals that we receive are displayed as dots, with their brightness being proportional to the amplitudes of the reflected waves. This is what we see on the display on the y-axis, while the x-axis displays time. The ultrasound machine is calibrated to think that the speed of sound in soft tissues is 1,540 meters per second, and this speed is constant. It will thus infer the location of a reflection based on the time it takes to come back to the crystal. With M mode, more than 90% of the time is spent in the receiving mode. Temporal resolution is determined by the time taken from one pulse to the next, also known as the pulse repetition period, and is affected mainly by the depth of the penetration. It worsens the deeper you go. M mode provides the best temporal resolution and superior axial resolution compared to B mode. M mode usage in POCUS. We see M mode usage when evaluating cardiac structures that are moving at a fast rate. Here's an example of the tricuspid annular plane systolic excursion or TAPSE. A scanline has been selected to go through the lateral annular ring of the tricuspid valve in the apical 4-chamber view. As we turn M mode, we're seeing the longitudinal systolic motion of the lateral tricuspid annulus towards the apex. The greater the displacement, the better the right ventricular function. We will be reviewing this further in the right ventricular function lecture. Alternatively, we can also use M mode in the lung. M mode can assist in the differential diagnosis of shortness of breath when we suspect a possible pneumothorax. We will want to see a seizure pattern in a patient with normal air-filled lungs. If there is a seizure pattern and then suddenly a barcode sign is present, this will represent lung point, which implies there is a pneumothorax. More on this when we review the lung ultrasound lecture. Color Flow Doppler.
As stated in the intro, the role of color flow Doppler is limited in the POCUS examination for your OSCEs. Major guidelines do not recommend the use of Doppler for any of the applications that we see in this series, including that of the heart. However, this may change in the future. This is a topic you should learn for your OSCEs since it's a requirement. The topics explored in this section are further reviewed in the evaluation of the heart valves. The Doppler principle can be applied to determine flow velocities, flow direction, and flow characteristics of the heart and great vessels. For now, let's focus on the basics.
The story of Doppler is the study of moving objects. A reflective and moving structure will have an impact on the waveform of the received pulses. As the sound source moves towards the probe, we anticipate an increase in sound frequency. Likewise, as the sound source moves away from the transducer, we appreciate a decrease in sound frequency. This moving target is the red blood cell as it moves throughout the cardiovascular system. The Doppler shift is the difference between the emitted and received pulses. The differences in frequencies is known as the Doppler shift frequency. It is impossible not to go over the Doppler shift frequency equation, and it is as follows. Doppler shift frequency is equal to 2 times the operating frequency times the velocity of the reflector times cosine of the angle over the speed of sound. The operating frequency of the probe and the velocity of the reflector are both proportional to the Doppler shift frequency, An increase in any of these two will increase the Doppler shift. The angle here is important and corresponds to the difference between the probe axis and the direction of the object. If both are in the same or opposite direction, the angle is zero. Cosine of zero is just 1. At 90 degrees, the whole equation vanishes since the target is moving at right angles from us, and so we would not be able to tell whether there's a change of speed. What this means to us is that we need to attempt to be in line with the flow of the moving target so that we can make an accurate assessment of flow. Color Flow Doppler displays intracavitary blood flow using a color flow map that depends on speed, direction, and turbulence of flow. Each frame of the color displayed is formed from multiple pixels. Each individual pixel is formed from sampling gates originating from the respective pulses. Imagine these gates as locations where Doppler shift interrogations are made. At each sampling gate, the frequency shift is measured, converted into digital format, and automatically correlated with a preset color scheme. This color flow map is superimposed over a two-dimensional image. Blood moving towards the transducer is displayed as shades of red and represents a positive Doppler shift. Conversely, flow directed away from the transducer has a negative frequency shift and is displayed as shades of blue. A yellow color display represents turbulent flow. It is important to remember to keep the color flow Doppler box as small as possible to obtain a high degree of temporal resolution. The more area you try to color, the more scan lines and sample gates it needs to calculate, which lowers the frame rate. Aliasing. Aliasing is a measuring defect that causes signals to become indistinguishable from each other. Picture a stationary wheel with an inner and outer spokes. You have a camera taking 24 frames per second, which is its sampling rate. The spoke begins to physically move clockwise at a faster and faster rate, as we see in these two clips. At some point, the spoke appears to be going backwards instead of forwards. This is aliasing and depends on the cycling rate of the camera. The spoke is going at least half as fast as the camera can create a frame. In ultrasound machines, many factors control the sampling rate. If the velocity of the measured object exceeds the sampling rate's capacity to display the maximum velocity, the wave's velocity is sampled opposite of its true direction. Therefore, the wave is displayed as a velocity profile on the opposite side of the baseline. Since the velocity is exceeding the maximum velocity of the scale, it is displayed on top of the opposite side of the baseline. The Nyquist limit represents the maximum Doppler shift frequency that can be correctly measured without resulting in temporal aliasing. The formula for Nyquist limit or frequency is as follows. Nyquist limit is equal to pulse repetition frequency over 2. Notice that we see listening time again. Remember that the Doppler shift frequency is 2 times the operating frequency times the velocity of the reflector times the cos of an angle divided by the speed of sound. Think of the Nyquist limit as a ceiling we do not want to go past. A high Doppler shift frequency is troublesome for us. This would mean the Doppler frequency is getting closer and closer to the Nyquist limit and aliasing can occur. What can we do to minimize aliasing? Probe frequency. Lowering the probe frequency lowers the Doppler shift since the operating frequency is proportional to the Doppler shift. Darker depth. Lowering the depth of measurement. The pulse repetition frequency is higher by selecting a shallow depth, and thus the Nyquist limit increases. Velocity of the moving reflector. Higher velocities will lead to a higher Doppler shift and thus a higher risk of aliasing. If such is the case, we should choose a higher Nyquist scale. How can we achieve this? Adjusting the Nyquist scale. We can adjust the Nyquist limit on ultrasound machines to select for low or high moving objects by changing the Nyquist scale. For high velocity flow, the pulse repetition frequency should be increased by adjusting to a higher Nyquist limit. Not all machines have this feature, particularly the portable machines. In these clips, we see a vessel being interrogated. The blood flow is physically going towards the probe and should be nearly all red on this color map. On the left, we see a low Nyquist limit and a high limit on the right. Aliasing is visibly occurring more on the left by having selecting a lower Nyquist limit and thus a lower pulse repetition frequency. We thus see a mix of blue and red when actually it should be all red, just like we see on the right clip. If there was a flow reversal, we would be seeing a transition of colors, with red, then black, and blue, which is not the case. The arrow marks the Nyquist limit. So far, we have seen what all ultrasound probes have in common. Let's take a look at these individually. Probe types. There are many different types of probes available that vary in shape, size, and technology. We'll focus on the probes you will likely see in your POCUS journey. These include the phased array, linear, and curvilinear probe. Linear probes are used when interrogating shallow structures and can have either a small or a wide footprint. The ultrasound image of this probe is of a rectangular shape. The operating frequency of these is high. This allows it to have great spatial resolution since both axial and lateral resolutions are going to be both high. The drawback is that these suffer significant attenuation, as we shall see in just a second. This means that we cannot see very deep. We will be using this probe when assessing the lung and in vascular ultrasound. The curvilinear probes have the widest footprint. These are used to visualize deeper structures at the expense of lower spatial and temporal resolution. Remember that the pulse length is higher compared to the linear probe and thus lower axial resolution. And B, that the diameter of the probe is slightly larger than that of the linear probe and appear to have better lateral resolution. However, the higher wavelength lowers the near zone length and thus has an overall worse lateral resolution. And C, the pulse repetition frequency lowers at higher depths, which lowers the temporal resolution. The sector looks like a fan that can be widened or narrowed. Narrowing the sector will reduce the number of scan lines and thus improve your temporal resolution. We can use this probe when assessing the lungs and abdomen. In the heart assessment, we can only use it for the subcostal view because of its large footprint. The phased array probes are used when scanning deeper structures and are indicated when scanning the heart. This probe operates at lower frequencies with a small footprint, which is perfect when examining between rib spaces. These have individual elements that can each be independently driven, and thus wave emission occurs at different phases. These ultrasound beams that are generated can be directed to improve the quality of the image produced by electronic steering. The sector looks like a piece of a pie that can be widened or narrowed, again having an effect on your temporal resolution.
Interactions with tissue. So far, we have made the assumption that sound waves do not degrade with depth and that all structures are reflective. That is not the case, which is why we need to look at the interactions of ultrasound with tissue. Even the most advanced ultrasound machines have interactions with tissue. This interaction is responsible for measurement errors, artifacts, and poor picture quality. It is important to understand how to avoid these errors and misdiagnosis.
As the ultrasound beam penetrates the medium, the beam loses energy. The beam is reflected, refracted, or absorbed as heat generation. The amount of penetration will determine the depth of the scanning area. Penetration is directly related to wavelength. Smaller wavelengths are more easily reflected and refracted in the superficial tissues than the longer wavelengths. A larger wavelength, on the other hand, will penetrate deeper. This is why you select probes with lower frequencies for deeper structures. Ultrasound waves interact with tissue in four basic manners. Those interactions include the following. Reflection. Reflection occurs when the ultrasound wave is reflected back towards the transducer. The major factors affecting the amount of reflection are the following. Angle of incidence. This is the angle of the ultrasound beam and the tissue plane. Tissue boundaries that are perpendicular to the ultrasound wave's path act as excellent reflectors, and if the reflector is smooth and the wave strikes at 90 degrees, then the reflection is strong and it's called specular. When looking at the apical four-chamber view, we see that the mitral valve, when closed, is at 90 degrees from the ultrasound beam, and the valve acts as a strong reflector. Tissue boundaries that are parallel to the ultrasound wave's path act as poor reflectors. When the ultrasound wave is not reflected, the ultrasound signal is not recorded, and the display shows a lack of signal or dropout of the ultrasound picture. Here we see an example of this in action, also in the apical four-chamber view, while looking at the intraatrial septum. It would appear there is an atrial septum defect, but because of the dropout, we cannot make this determination. To get this structure as close to the 90 degrees to the ultrasound beam, we will use the subcostal view as seen here. Acoustic impedance. Acoustic impedance is the ease with which the sound wave propagates through the medium and is determined by the density and stiffness of the tissue. Think of it as the resistance to ultrasound transmission. When the ultrasound wave travels through one medium to another, a change in acoustic impedance occurs. This amount of change will determine the amount of reflection and thus what you see in your ultrasound screen. Large changes in density between two tissues will result in a large change of acoustic impedance. The difference in acoustic impedance between two tissues accounts for the amount of reflection that will occur at the tissue border. This is why we cannot interrogate deep lung tissue well with ultrasound. since the majority of the ultrasound waves are reflected at the plane between the pleura and the lung, and thus very little ultrasound penetrates any further. Another example is as follows. On these clips, we are visualizing the same supraclavicular structures. On the left, the probe has been used without the use of ultrasound gel. On the right, with gel. The absence of gel makes for a high acoustic impedance, and thus we start with limited ultrasound transmission. Notice the area of absence of echoes denoted by the arrows because of the high impedance. The higher the acoustic impedance between two tissues, the less ultrasound waves penetrate. Refraction and scattering. Refraction is reflection where sound strikes the boundary of two tissues at an oblique angle. The reflections generated do not return directly back to the transducer. Refraction occurs when the ultrasound signal is deflected from a straight path and the angle of deflection is away from the transducer. Refraction only occurs at a different medium interface of different acoustic impedance. If the propagation velocity is greater in the first medium, refraction occurs towards the center or it converges. If the velocity is greater in the second medium, refraction occurs away from the originating beam or diverges. The side lobe artifact is an example of refraction. The main ultrasound beam generated by the crystals as they vibrate are not the only type of beam generated. The crystals also vibrate radially, creating less intense ultrasound side lobe beams. When these side lobe beams reflect sound from a strong reflector outside the central beam, echoes are displayed as though they are originating from the central beam and thus appear in the center of the ultrasound display. This transverse view of the urinary bladder displays this kind of artifact. There is only urine in the near field of this urinary bladder, even though the reflectors have caused side lobe artifacts, making it appear as though there is something there. Scattering occurs when ultrasound waves encounter objects that are small compared to the size of the ultrasound's wavelength. This will diminish the intensity of the return signal. Attenuation. Attenuation is the reduction in amplitude of the ultrasound beam as a function of the distance through the imaging medium. As the ultrasound wave travels through a medium, the medium absorbs some of the energy of the ultrasound wave. During attenuation, the ultrasound wave stays on the same path and is not deflected. As it passes through tissue of different densities, the amplitude decreases. Once all the ultrasound wave energy is absorbed, then structures distal to this point of total attenuation will not be visualized and will appear to be dropped. Attenuation is proportional to the depth of penetration and is dependent on the frequency of the transducer. This is the major drawback of high-frequency probes, their high attenuation. Low-frequency probes have better penetration and are therefore not attenuated as much as high-frequency probes. Acoustic shadowing is a type of attenuation artifact. Acoustic shadowing by the rib cage is caused by partial or total absorption of the sound energy that prevents us from seeing structures that lie deeper. Attenuation is also proportional to an attenuation coefficient. Bone has one of the highest values, while blood has one of the lowest. In this example, we see rib shadowing, and it makes it hard for us to see the liver and kidney. Absorption. Absorption is the portion of the wave energy converted into heat energy. As the tissue can absorb energy to produce heat, an increase in temperature may occur. An increase in the power of the ultrasound beam will result in an increased potential for tissue heating. The smaller the scan area, the greater the energy passing through it. Strongly focused fields will produce particularly significant temperatural increases. Higher frequency sound waves are absorbed more than lower frequency sound waves. The inability of high frequency sound waves to penetrate deeply into tissue is a direct result of high absorption and conversion of acoustic energy into heat. Absorption contributes approximately 60 to 80% of the total attenuation. The higher the attenuation coefficient, such as bone, the higher the heat generation.
Biological safety. It is generally accepted that the diagnostic use of ultrasound is harmless for humans. However, it is important to realize some key features of ultrasound safety.
Acoustic power is the amount of sound energy carried in a unit of time, and power is proportional to the square of the wave amplitude. Two standard indicators of acoustic power and biological risk from ultrasound are defined as the mechanical index and the thermal index. The mechanical index is the indicator of potential non-thermal mechanical effects, including cavitation. Here we see the effects of cavitation on a bottle filled with fluid, which is then struck by a rubber mallet on the mouth. Cavitation is determined by the negative pressure of the ultrasound beam. The Food and Drug Administration regulations allow a global maximum mechanical index of less than 1.9 for the applications in this series. A much lower mechanical index is required for the evaluation of the eye. The thermal index is the indicator of potential temperature increase. It is important to note that color Doppler will have at least 8 times the amount of acoustic power compared to B mode. In general, the performance of ultrasound scans should comply with the ALARA principle. This is as low as reasonably achievable. A note about power. Increasing power allows you to see higher returning amplitudes. Here I'm showing you 3 different clips of the same structure for altering the power setting of the ultrasound machine. The effect of changing the power on the mechanical and thermal index can be seen reflected on the data on the ultrasound display. It is unlikely you'll be making a lot of changes on the power of the ultrasound beams routinely.